Well, welcome back. I think we'll get started our afternoon program. And with apologies to folks who are here right from the beginning for our workshop, I'll just re-welcome you, but also welcome our folks who have joined the meeting over the course of the morning. I'm Michael Berry, President of the Informed Medical Decisions Foundation, and it's great to have you here for our meeting on aligning incentives for patient engagement, enabling widespread implementation of shared decision-making. And we've had, from my perspective, a great morning where we've heard from both providers and patients trying to make patient engagement real. I think we've poked a hole in the bubble of the notion that patients don't want to be involved, whether through the talks of our patients themselves or the data Jack Fowler presented earlier. So now we have to think about the system and how we can align incentives to make this happen routinely rather than just in unusual circumstances. And you're going to hear from a lot of people over the course of the rest of the meeting who have been trying to do this day to day, discovering the barriers and figuring out ways of overcoming them. As I mentioned this morning, one of the things we want to do is think through with you what are the specific steps that different people or organizations can take to make shared decision-making a reality in terms of aligning incentives, whether they be incentives aligned at patients, at health systems, at individual clinicians, and that will be the, if you will, the output of the conference. I once again want to thank the Gordon and Betty Moore Foundation, Dr. Dominic Frosch, who spoke this morning, Dr. George Boleyn, who's also representing the patient care program at the foundation, for working on this conference with us and nicely sponsoring it. So again, as you begin to think about the presentations over the course of the afternoon and tomorrow, be thinking about what are the specific steps that we could take together or individually that would make implementation of real patient engagement and particularly shared decision-making writ broadly, whether it's decisions about big single-time events like hip surgery or the lots of little decisions that are about part of chronic disease management or sleeping better. How do we make that happen, and what are your ideas for how we could change the system and maybe the culture to facilitate that? So to continue on that theme, I want to introduce our first plenary speaker, Christine Bechtel. And she's an advisor for the National Partnership for Women and Families, a nonprofit consumer organization that's done so much to assure equity in the workplace and to improve the quality of health care for all concerned. She focuses on issues such as patient and family engagement, quality measurement, and health IT. She also serves as an advisor to the Casey Health Institute, a nonprofit primary care practice in Gaithersburg, Maryland, where she focuses on patient and family-centered care, very relevant to our conversations today. She was previously vice president of the National Partnership, providing strategic direction and oversight for the organization's day-to-day work. Christine has also formally served as vice president of the eHealth Initiative. She's worked with the American Health Quality Association, and she was a senior research advisor at AARP, so has been working in this area for a long time. And we're delighted to have her this afternoon to share her perspectives on patient engagement in general, shared decision-making in particular. Christine, welcome.
Thank you. Well, thank you very much, Michael, for the very kind introduction. It's really terrific to be here, and what a fabulous meeting so far. Congratulations to you. There's been so much attention recently on patient engagement, and it's very nice to see. We had a health affairs issue that actually was included in your materials today, which was published back in February. The whole issue was on patient and family engagement, and that is really thanks to the terrific thought leaders like the Informed Medical Decisions Foundation and like the Gordon and Betty Moore Foundation, who are really bringing some commitment and resources to these issues. And I think in terms of shared decision making, without the Informed Medical Decisions Foundation, we wouldn't be where we are today. So really applaud you for that. So I think when it comes to enabling widespread implementation of shared decision making, I think it's actually this increasing interest and focus on patient and family engagement that is really a key driver of the larger context that is going to offer us some hope here about more widespread implementation. And I think it's an interesting term, right? We've just spent the morning in a great workshop on patient engagement and on shared decision making. It's a term we all are familiar with, of course. We use it on a regular basis. So I'm going to ask you two quick questions, show of hands. How many of you feel confident that you could define the words patient engagement? We just spent a morning on it, people. Don't be shy. Okay, keep your hands in the air if you think the person or the people sitting next to you would define it the same way. Okay. So obviously it's a little bit like a Rorschach test, right? That's always been our experience too. It kind of means different things to different people, and we aren't always talking about the same thing. I think most commonly we talk about engagement in care, and sometimes that is about changing patients' behavior or asking them to take responsibility. We've essentially built a system that we're trying to engage patients in the processes and the outputs that we think are right for them. But I'm going to argue that's not quite right, not quite where we need to be. And I actually want to tackle that particular conceptualization of patient engagement very directly and say that at this point, and I think this morning helps to reinforce this enormously, I don't think it's about patients' behavior change. I think it's about the system and changing the system's behavior as a whole. And sometimes that includes patients and families. But this singular, more narrow focus on only engagement in care or on the actions and behaviors and motivations of patients has really failed to produce the results that we have all been seeking, despite decades, really, of effort. We're still, frankly, left with a system that is too costly in both financial but also in human terms. And not just for patients and families, but for clinicians as well, right? We keep hearing a lot about bringing the joy back to practicing medicine. Absolutely, we need to do that. So when we step back, or at least when I step back and I think about this idea of patient engagement, it strikes me that the concept isn't terribly common in other industries. I mean, I don't hear the technology industry talking about customer engagement or geek engagement or nerd engagement, or whatever you want to call it. And I am one of those, so I can claim it. You know, as I think about airline and banking industries, I don't hear banks trying to talk about changing the behavior of their customers or taking customer responsibility, for example. It's a language that's relatively specific to healthcare. And again, I think it is a symptom of a system that was built for patients, but not with patients, not by patients, right? So it isn't meeting our needs to the fullest extent, and I think as a result, the sector has been in a period for several decades of trying to bend consumers to it instead of building a bridge to them as partners, God forbid clients, right? And so I think if it were working for patients, though, we wouldn't probably need to use words like patient-centered care. It's David Goldhill said to me, he was the CEO of the Game Show Network, actually. Some of you will know about him. Michael was with me when we listened to one of his talks, but he had an experience caring for his father over the course of many weeks in a New York hospital. And he said to me, you know what, if you have to call it that, it probably isn't that, you know. You don't hear Walmart describing itself as customer-centered. And I think that's a fair point. And in fact, our research does show, we heard a little bit of it this morning as well, that patients and families want shared decision-making. About 2 years ago, the National Partnership conducted a series of focus groups across the country in English and in Spanish. We followed it up with a national survey, and it was designed to really figure out how to talk with consumers about delivery system change. It was in the period when ACA was being drafted and in passage, and we knew we were going to need to describe things like health information technology and patient-centered medical home. Clearly, by the way, a name that was come up with not by consumers. And so we tested a series of ideas. Again, try to figure out how to explain them. Health IT, medical home, which we called, by the way, medical home base, still totally didn't work. We tested quality measurement. We tested payment reform, and we tested shared decision-making and patient experience. And what consumers told us unequivocally, top two were health IT. We which I was surprised that that was number one, and patient-centered medical home. And that was because they spoke to the most acute challenges that patients and families face in the system today, which center on care coordination and communication. And when it came to shared decision-making, what was very interesting about that was they said, this doesn't feel like a solution. And we almost were apoplectic. Well, what do you mean? What do you mean? We've been working on this for decades. And they said, well, it feels like a fundamental right. What's new about it? Okay, fair point, right? They said this is not a special thing that we should hold out. This is a basic expectation and a fundamental part of my role in the healthcare system. So it was very different, I think, than what we expected to hear. I think that's backed up by a lot of the experience in the field today. We're going to hear from Grace Lynn from Palo Alto as well during this meeting, and at the IOM meeting that we had a couple months ago. It was back in February, also, by the way, supported by the Gordon and Betty Moore Foundation. We heard about how Palo Alto had an experience where the clinics actually stopped providing shared decision-making materials to patients because the volume was so difficult to manage, right? So as Michael said, I don't think there is any debate that consumers really want shared decision-making. And yet we haven't implemented it on a widespread basis for many of the reasons we've all known about and talked about. But I think one of the major reasons that we still struggle to implement shared decision-making on a widespread basis is our limited definition of patient engagement, where we focus on care and we focus on behavior change and taking responsibility. And it's really rooted in a pretty problematic cultural view of patients as passive recipients of care. And that view simply can't hold up for much longer because it's really failing us. So the good news is that over the last couple of years, a deeper and more multifaceted definition of patient and family engagement has emerged and begun to take root, slowly but surely. I had the privilege of working with some colleagues at the American Institutes for Research, at NQF, and also with Shoshana Sofer on crafting an article in the February issue of Health Affairs that looked at this emerging definition and its dimensions and tried to crystallize what was happening in the environment. And so what we proposed and what we described is that patient and family engagement at its core is really about a partnership. And it's about a partnership to improve health and care and health outcomes at three different levels, right? So the first of which is the care level. That's where we've been focusing a lot of our discussion both today but also historically. But this is a little different than the take responsibility behavior change elements. This is about a real partnership where we have a conversation about my goals and what's important to me and what's motivating to me and what my values and preferences are and how my conditions factor in. And we use the combination of clinical judgment and expertise with my own expertise and judgment about who I am to make the best decisions for me. So that's the essence, right, of shared decision-making, is really rooted in that partnership. The second level is engagement in care process redesign. So working to design the system itself together and co-recreate it, if you will. So how should, in the example of shared decision-making, how should it happen? Where should it happen? Who should do it? How long should it take? All of those process questions that we have. How do we make it work for both clinicians and for patients and families? But also even, perhaps more common problems that we see a lot. How do we reduce wait times? How do we deal with high phone call volumes and other inefficiencies? How do we improve patient experience? How should we help people with diabetes achieve optimal levels of health and functional status? We need to ask patients and families and co-create that system with them. So the third level of patient and family engagement is really partnership in governance. At an organizational level or at the level of an initiative, or here we are in Washington at the national level of public policy. So this is around how do we set policies that really govern both the operation and, if you will, the incentivization of our system. So that could be serving on a board of directors, party foul, That could be setting job descriptions. It could be setting national qualification criteria for accountable care organizations or patient-centered medical homes, because patients will bring that voice of what's important to them and push for things like shared decision-making to be included in them and to be incentivized and rewarded by them. So how do we enable patients and families to help govern the systems that they have designed with us and that they are the center of? So I think sometimes it's helpful to think about engagement and also in terms of what it's not. So it's not just education campaigns or compliance or good patients or consumer-driven healthcare or smart consumerism. Those things still feel to consumers like getting them to do what we want them to do. But we need to pivot and ask them, what is it that you need from us to get you where you want to be? And that's a different lens. So again, thinking of industry as a model, when we go to buy a car, we don't think, oh, gee, consumers should really participate in shared decision-making around the options that they want to select, even though that's a highly preference-sensitive condition, right? It is a fundamental part of the process. Although I'd love for somebody to study, the impact of choices on things like backup cameras. Does everybody else have this problem? I can't back up a car anymore without a camera. It's terrible. Anyway, I digress. So the fact is, about shared decision-making, consumers are already there. So that tells me that they're not the locus of behavior change at this point, right? I think that we need to focus on the healthcare system and how it values and what its culture is, first and foremost. So it reminds me of the book, Culture Eats Strategy for Lunch. And so I was looking at it the other day, and I thought, I want to read you a quick passage, because I think if you think about the parallels to healthcare, and I'll let you draw them on your own, it's very interesting. So he says, get on a Southwest flight to anywhere, buy shoes from Zappos.com, pants from Nordstrom's, groceries from Whole Foods, anything from Costco, a Starbucks espresso, or a double-double from In-N-Out, and you'll get a taste of these brands' vibrant culture. Culture is a balanced blend of human psychology, attitudes, actions, beliefs that create, combined together, either pleasure or pain, serious momentum, or miserable stagnation. A strong culture flourishes with a clear set of values and norms that actively guide the way a company operates. Employees are actively and passionately engaged in the business, operating from a sense of confidence and empowerment rather than navigating their days through miserably extensive procedures and mind-numbing bureaucracy. So those are indications of culture, and I'll let you decide who is the patient and who's the clinician in that little scenario. I think I can see it both ways. But what I want to argue is that this is a cultural problem, and that changing our, enjoying or engendering a cultural shift in how we view patients and families is essential. How we enable their norms and values to blend with those of clinicians and health plans and employers and all of the actors in the system to help guide and help govern it. In other words, it's a very different view of patient and family engagement, not as a goal anymore, but as a strategy. As a strategy for getting to better health outcomes, more cost-efficient, better experience in the healthcare system for patients, for families, but also for clinicians and everybody who plays a part in it. So this is a recognition that the strategy is engagement at all three levels in care redesign, and governance, and how it operates. So to get there, and to get to more widespread shared decision-making, I think we need a couple of things along the pathway. And we heard, I think, some really great examples this morning, and we're going to hear more this afternoon of pockets of places that are doing these things, that are beginning to align incentives and achieve the kind of shared decision-making that is really a hallmark of patient-centered care writ large. So number one, I would say tools and workflows. We need to make the right thing to do the easy thing to do. Right? Clinicians are busy. How do we create the time for them to engage in shared decision-making? How do we use team members to their fullest capacities? How do we think much more broadly about who the team is? I think the field of shared decision-making has done a really good job of exemplifying that, whether through using medical students or retired healthcare professionals or health and wellness coaches, but it doesn't always have to be the doc doing the engagement and shared decision-making. So reconceiving this idea of who is on the team and how it operates. Also thinking, I think, to Bruce's comment, how we have enough decision aids that are really going to advance consumers' decision-making ability. And in the case where we don't have enough evidence to point to a particular direction or not, how can the process overall really crystallize and help patients and families articulate their values, their preferences, their goals, so that it is through that lens that they might make decisions instead of just an evidence-based lens, right? Health information technology, essential tool for shared decision-making. It is not only a very helpful way to automate the process of identifying the patients in a patient population that would benefit from shared decision making, but it's also really essential to cataloging their life goals, their preferences, the recording the outcomes that they want to achieve. When we did focus groups, and we also did quite an extensive bit of work to convene patients and families and talk to them about patient-centered care. They said, I want my doctors to know me and remember me. That's not easy to do when you're talking about 5,000 people or more. But health information technology, I think, is certainly an essential tool. I also think, though, that we can use technology to begin to deliver the shared decision-making aids in the ways that we are seeing and using consumer technologies in almost every other aspect of our life. We are using technology today to help fit into our busy lives the things that are important to us. But we seem to still have a culture in healthcare that is asking patients and families to jam their life into the healthcare system. Sure, come and see us between the hours of 9 and 4, and oh, by the way, we take a 2-hour lunch, right? So how do we use technology to introduce efficiencies into the process for patients and families and for clinicians that will help us facilitate shared decision-making? So next, measures. We need to understand and measure whether shared decision-making is being done well, both from the patient's perspective and the clinical team's perspective, and also the performance of the system as a whole. So in other words, the health outcomes and the quality of life and the cost goals that we're all working towards. So when I think about that, I think about things like, how did patients and clinicians experience the process of shared decision-making overall? Did patients feel listened to and supported? I had heard the UCSF Breast Care Center mention once that their motto was listen first and listen fully. Did that happen? If a patient had a preference-sensitive procedure, is there evidence that they were offered or given tools to help them make a decision around that procedure? Was the outcome concordant with their values, preferences, and their life goals? Are costs coming down? Are quality and outcomes going up, right? So I think then we need to use those measures not just to assess and perfect the process and the workflow and the tools, but also to begin to introduce both accountability and incentives into the system in a way that really rewards the things that we're all looking to reward. When we talk to consumers about payment reform, for example, they rejected the notion absolutely, and it was for the reason actually Angela said well this morning, which was they said, what do you mean you got to pay my doctor extra to do the right thing? But when we said, okay, but did you know that your doctor doesn't get paid to call another doctor and coordinate your care together? They went, oh, well, that's ridiculous. They should get paid for that. Same thing with shared decision making. So how do we leverage the new models of care that are emerging and expanding, like accountable care organizations, patient-centered medical homes, and others? They can be major drivers of shared decision making, as can employers and health plans. I'm staring down Andy in the back of the room there. If they use the right kinds of tools and measures that are going to really help us get to the kind of shared decision making that we all want to see and reward the outcomes that we know shared decision making is capable of producing. So at the end of the day, what I would say is shared decision making is both a reflection of and it is central to this whole notion of patient and family-centered care and achieving better health outcomes. But we can't build the system for patients, even with the best of intentions. So that's really the essential question that we face now. If we build it, will they come? So I would submit to you that if we build it with them, they will already be there, and we will get there faster. Thank you.
Take some questions.
Yes. Do you want to moderate from here?
Sure. So Christine raised a lot of interesting thoughts about setting agendas with patients, using IT. I'd be interested if there are reflections on her suggestions or maybe things that you're actually doing in the audience that are picking up on these ideas. Let me start. This issue of eliciting an agenda, or building an agenda with a person, a patient over time. And this came up a little bit in the questions around Jack Fowler's presentation. There's both the issue of getting to know someone's values over time, what's important to them, and also their values around a specific decision, which may not be the same. Do you think of a way of operationalizing that?
Sure. So a couple things come to mind, and they all, by the way, do involve the use of health information technology to catalog and record and remember, because it is hard to remember over time. I think we did hear a great suggestion this morning from a clinic that was using, prescription pads to ask patients to write down the 3 things that were most important to them in the visit that day. And I think we can adapt that to help think a little bit more broadly about what's important to me in my life. So if you know anything about me, and some of you do out there, and this will be a ridiculous sounding example, but it's appropriate. My big motivation and passion is that I play golf. So if you want me to do my physical therapy exercises like I'm supposed to, and which completely bore me, and it's an amazing how bad I am at doing them, you'll connect it to golf, right? And that was what happened for me. I got engaged and became an activated patient when I had a physical therapist who said to me, if you want to achieve your goals on the golf course, this is what you're going to have to do. And it was completely motivational. But if you remember that over time, and for whatever reason most people do, then it helps to know that when I am facing a question about back surgery, which I did, what's important to me is I want to get back out there and be physically active and fit as soon as possible. I want to do this, I want to do that, and what's my pain tolerance level. So I think using the instruments that we have that get to know patients as people will be really essential, and that's both, I think, a workflow, but it's also a care team and a people issue. And Helen Burson and I actually were having a conversation in the hallway where we talked about the important role that MAs play in getting to know and having those conversations and eliciting those values and those stories, and then transferring that knowledge to clinicians, and I hope putting it in an electronic record somewhere. So I think that would be a helpful approach.
I'll just add that in terms of helping people make end-of-life decisions, and often families as well, not only having those conversations about values, but encouraging them to share them with family members and actually documenting, whether it be with a formal advance directive or I've done notes in the record, about families coming to consensus around what should be done to honor preferences.
The other thing I would suggest is the disabilities community has done some really fascinating work around person-centered plans, not care plans, and they're not medically based, but it is the same concept of articulating my goals and services and supports that I need.
Great. Dr. Boleyn.
Hi, George Boleyn of the Gordon Betty Moore Foundation. Thank you, Christine, and thank you for the acknowledgement of the Gordon Betty Moore Foundation for the IOM event and also for co-sponsorship of Health Affairs for the February issue. But 2 questions. One is, we've heard a lot about this cultural change. Do you believe that the cultural change on the part of physicians particularly, but healthcare professionals in general, can be changed by financial incentives? And if so, how and when? If you don't believe that financial incentives alone can do it, what are your thoughts on some of the work in the UK on health social movements, creating a collective identity across, in some instances, the area of behavioral health or the areas of breast cancer awareness, and others that bring about a sea change culturally amongst those who desire to be engaged but are rejected by the system?
Very good question, and the short answer is I don't think incentives alone will do it, but I am drawing an analogy to the Meaningful Use program in health information technology. And say what you will, what I have noted is that over the past 30 years, the proportion of clinicians with an electronic record has remained somewhere in the low tens and teens. And it wasn't part of our culture of medicine to use technology in that way. But when financial incentives and penalties were introduced, we are now literally, as of this past week, at a tipping point where a majority of hospitals and doctors now have electronic records. I think it's an important facilitator to jumpstart the culture change, but I think it doesn't get to culture change at all alone until you begin to experience the benefits. And so I think when clinicians are to a place where there is an incentive, there is a measurement, there are a set of tools that make the right thing to do, the easy thing to do, and begin to experience the benefit of being in a genuine partnership with patients, I think they have to be there to experience it in order for culture to really change.
And then the comment about health social movements and the collective identity, which is a key part of that success in the UK.
You know, that I'm not familiar with, but I'm very interested to learn. Thank you.
Let's go from here.
Hi, Susan Frampton with Plaintree. Christine, I wanted to thank you for some of your comments, particularly around looking at shared decision-making from the larger perspective of how it fits into patient-family engagement and patient-centered care. I think that's a very important thing to keep as a foundation there. And I do believe that one of our largest challenges is preparing the ground for it, and that preparing the ground is the culture change piece that you alluded to. And in the work that we've been doing for 30 years, we've been asking patients and families and direct caregivers those very questions of what does it mean to be a patient-centered experience for you? How do you define it? What's most important to you? And many of the things that you mentioned in your talk touched on what's most important to them. And by the way, I think we never want to forget that it's patients, families, and caregivers, that caregivers are an important piece to this whole equation. So I want to just make sure that we don't lose one of the things that we've heard over and over again from patients and families and caregivers about what's most important to them, because I think that it could be a key both to the culture change piece, but also how do we make sure that the tools that we use are effective. And that concept that I haven't really heard yet made explicit is the concept of compassion in action or compassion in practice. Because when we talk with patients and we say what's most important to you about your interaction with your healthcare team or your providers, they'll say caring, kindness, and compassion, respect, being listened to. But that caring piece, that kindness thing is very, very important to human beings, and I wouldn't want to lose that in our thinking about how we make the most of the tools that we have. I'm just wondering what you've heard in some of the work that you've done around
Thank
that.
you. I'm really grateful, Susan, that you clarified that point, and I couldn't agree more. I think what we hear from patients and families is exactly that. They tend to talk, as we've listened to them, more about the relationship and the trust, but what is under that is the caring and the compassion. And in my work now with the Casey Health Institute, what's interesting is that this is a group of physicians that when I said, well, what is it that you want to know from your patients when we think about doing a patient experience survey, their first instinct was, oh, I want to know if I'm connecting with them. I want to know if they feel like I care about them. So I think it's really interesting to see the culture on both sides driving towards that. And thank you. Great work at Plaintree, too.
Yeah,
thank you.
Thank you. And I just want to point people's attention to the growing body of research evidence that essentially says that connection between empathy and compassion now is correlated with better health outcomes in all sorts of different ways. So it's great to have that scientific backing as well.
Thank you.
Thank you. Please.
Hi, Lauren Kennedy with the National Partnership for Women and Families. And I was wondering if you could address or expand upon some of the foundational work that needs to be done with patients or consumers so that they can engage on sort of care process redesign or governance of the sort of redesigned system so that they can sort of meaningfully participate and move the agenda forward and not just be sort of the token consumer representative on a governance board or something.
Yes, I've been there myself. Thank you. Good question. So I think we are seeing, and actually there are some examples that we heard about this morning as well, where there are an increasing number of health systems that are recognizing that it's no longer just about, for example, a patient and family advisory council, that that's an important component when it's meaningful and impactful and it's listened to and it's connected to leadership, because that's how you drive culture change, but that it's also about embedding consumers in the very quality improvement processes that the institution is implementing on a daily basis, and looking at this as a strategy for accelerating improvement. And so what, as you know, the National Partnership has done a lot of work around figuring out, first of all, how do you help the clinicians understand this as a strategy for change, and then supporting the patients and families as they engage in those ways to make sure that they've got what they need, which is typically the ability to understand the language, right? We have a particular lexicon in healthcare. So how do we understand the language and speak the language? It's also been, I think, helpful to provide backup strategic coaching around how do you move an agenda forward in an environment that you're talking to the hospital CEO and you're talking to the chief medical officer and you're talking to people who have a different background and skill set than you do, and you need to effectively and collaboratively move something forward, not as a bomb thrower, because nobody likes those people, but as a collaborative partner. And I think those are some of the skills that we found have been really helpful to develop. Thank you.
Please.
Thank you. Barbara McEnany. I'm the oncologist who has the Innovation Center grant for the oncology medical homes.
Oh, great.
And I wanted to comment first on your comments about requiring financial incentives. I think it's more of a process of removing the disincentives. That to innovate any new program, to add any decision support functions, to do those kinds of things in a practice requires a significant amount of money. It requires personnel, it requires training, it requires the time to look over the tools and decide that they're adequate. And it requires a lot of work on the part of the physician, which means time not spent seeing patients, and it requires a lot of unreimbursed services. So I think that rather than looking at what are we providing for financial incentives, I'm hoping part of your process going forward will be to look at where those disincentives are and make it possible to do that. Earlier there was discussion about why aren't people grabbing onto this program and running from it, and putting it as part of the practice. And I think one of the reasons is, frankly, most physicians don't know it's there. And secondly, I think one of the issues is we don't know who are writing the decision support tools. So just the cynical part of me would say if you have the local health plan writing the decision support tools, then perhaps it would be slanted towards palliative care and hospice rather than active treatment for a given condition, because that's a whole lot cheaper. For the managed care people, will have to forgive that analogy. But if you had it written by somebody who is very much invested in doing surgery, it would be slanted towards doing surgery, or radiation, or chemotherapy, or whatever. So how do we know when we adopt a tool that the tool we're doing is actually going to give an unbiased approach, or as unbiased as is humanly possible, so that we can trust that decision support tool? So that would be two questions, I guess. Sure. The disincentives and the quality of the tools themselves.
Sure. So to the disincentives, I agree, but I do think it is a blend of both, because at the same time, you really need to facilitate the building of the infrastructure, which is in part what you've described, but it is also about making time with patients rewarding, right? That our fee-for-service system, and maybe we're saying the same thing in two different lenses, but yeah, I mean, I think you're right, it's a disincentive, but I also think then, we have to also build the right incentive structure in, so perhaps we're saying the same thing on that. With respect to the quality of the tools, I actually want to defer to Michael, because he has led some terrific work around looking at certification processes and what happens internationally.
So I think in terms of aligning incentives, again, the concern you raise about how do you know you have a good tool is a fundamental one. So there is an international patient decision aid standard group that looks at both evidence and expert opinion on elements of what make a good decision aid. There's a fair amount of there are areas where we need more research to be absolutely sure of all those facets, but it's a pretty good starting point. There is a call starting in Washington State. There's actually a mention in the Affordable Care Act about certification of decision aids. And I think in terms of aligning incentives, a certification program would be helpful, probably based on the IPDAS standards as a starting point that would give both clinicians and patients confidence that the tools are good ones. The issue of bias is an important and tricky one. So one would want, for example, the opinions of specialists in the area to be integrated into the tools, but probably a specialist that only does one thing, making the final decisions about the program isn't a good idea. Similarly, drug and device manufacturers, what's their role in developing these tools? And the IPDAS Standards Committee is wrestling with that. Personally, we're concerned about it, and at our foundation, we don't accept funding from those sources to develop decision aids in that regard. We test programs for balance, but it's a tricky issue because if a program appears to a viewer slanted in one direction or another, is it that we haven't made the program right, or is the truth that the evidence sort of supports one option more than the others? Colorectal cancer screening has come up as an example here. So when patients rate our program on colorectal cancer screening, and if you ask, is it biased towards screening or not, they in fact will say it tends to be biased towards screening. I would argue because the evidence really supports screening, we do present not screening as an option. Now, the other choice about fecal occult blood testing versus colonoscopy, et cetera, I think is a legitimate choice, but people will argue that as well. So bias is in the eye of the beholder, but working hard on it and perhaps a certification program might be helpful.
I'll just add one thing to that. There are large parallels between the challenge that we face with decision aids and the challenge we face with electronic health records. And so we, of course, have created a certification process for electronic health records. The thing that it does not address, though, is usability. And that's a different issue, right? And we really, I think, thought that the market would address usability, that clinicians would sort of gravitate to the better ones, and there would be, communities reviewing, and it's not happening, at least on the pace that everybody hoped. So I think it is important to keep an eye on that track of usability and perhaps thinking about how to incentivize some of our application developer friends from Silicon Valley and who are thinking in really innovative ways about the way people learn and want to absorb information. But that's a separate track from certification.
Marcus?
Christine, thanks so much for this great presentation and for really emphasizing the role of culture here. And I was struck by the commercial organizations that you listed at the beginning of your talk and how distinctive their cultures are and how important those cultures are in terms of their commercial success. But it seems to me that all of them actually essentially develop those cultures de novo. And they don't represent legacy organizations that underwent, as far as you might be able to have an example of one that's different. But as I recall the list, they're all sort of new entrants in the marketplace that basically came out with new cultures, and those cultures are part of their success. What we're dealing with here is a legacy system, if you will, which has got a deep, pervasive, and persistent culture of being provider-centered. And not being, in fact, we have to call it patient-centered, as you said, means we're not. And I guess the question I'm asking you is, can you think of any examples where you've really seen really meaningful and dramatic culture change in existing legacy systems, or are the implications of your comments perhaps that we really need to be thinking about really truly new and disruptive innovations in care delivery where we start from the beginning with culture? And I'll just make one other comment to kind of emphasize the relevance of this point. You know, in California, obviously, we have a lot of Kaiser Permanente and Permanente Medical Group organizations, very successful. But as I understand it, Kaiser struggled with replicating that model around the country, and in part it's because the original foundational culture of the Kaiser organization was established very early by a few individuals who created the simple rules about what it meant to be a Kaiser doc. And that culture then has really driven that organization's performance over time. And it's not so easy just to replicate it, let alone go into an organization which has a very different culture and change it to that. So curious whether you think we have to go with the disruptive innovations or really can make changes in the existing legacy systems to adopt the culture you're recommending, and that I agree with.
I actually think it's both, and I think at least the disruptive change reinforces the change, because we're not going to get rid of our legacy systems, as you've described. Those are going to be around as institutions. But I don't mean to imply that healthcare hasn't culturally changed. So we came from a place where we literally did things to patients without their knowledge, and it took the Supreme Court intervening to say, no, you got to tell them what you're doing to them, right? We are so far from that point at this time in history, and that was, a million years ago. So it's a slow pace in some ways, but it is changing. And so I think those legacy systems are capable of change. And it is the same lessons from culture change as anywhere else about leadership and the right incentives and the right tools. But I think the analogy that I'm making is also designed to draw attention to the fact that these are branding organizations. Okay, so the retail business has been around as long as or longer than healthcare, right? So as retailers, they have changed their culture and they focused on branding. But what we're seeing in healthcare today in branding is we're calling it patient and family-centered care. I hear that on the radio today. I hear advertisements about, institutions using an electronic health record. Am I going to get the hook?
No,
I think I am.
fine.
Anyway, can you imagine now your bank talks about online banking, but that's a benefit to you, and I think it's a little bit different than, hey, we just revolutionized our internal bank system that lives behind this curtain that you never see, right? So it is just a really problematic focus, or not problematic, misplaced focus in that respect. But I actually think it is symptomatic of the culture of healthcare trying to jumpstart its own change. I think it's a long path. Disruptive innovation will absolutely help and accelerate the path. But let's not forget that there is a big very old, very stale institution that plays a humongous role in shaping national payment policy that lives right up the street. So we have our work cut out for us, right? Congress, not GW or anything. I don't want to be, it's all good. But anyway, so thank you. It's a very astute observation.
You've lifted my spirits.
And I do think we have time for one last question.
Sure, I'll make it a very quick question. So I'm Josette Bamuda. I'm from the National Governors Association. And my question really centers around, it's a slightly different question. It centers around kind of the transparency and accessibility of pricing and quality information that's targeted at patients. So I know we're working a lot with our state partners, especially those who are designing state healthcare innovation plans. And the question that keeps bubbling up over and over again is, how do we get the information to consumers and make the information actionable so that indeed it does inform their decision-making behavior? Do you have any recommendations? Have you had focus group discussions around this that you can perhaps share and provide some insight on?
Sure, and I'm happy to give you some connections and resources offline. Actually, the Pacific Business Group on Health has done a lot of great work with us on this front. But I would say two things. In a direct answer to your question, consumers, the information needs to be available at the point at which they need it. So for me, if I have a high deductible health plan, which is the most common scenario where I'm going to look for pricing information or an HSA or something like that, I'm going to call the doctor and I'm going to ask how much you charge for an office visit. And they almost never know the answer. Mm-hmm. Or I'm going to be in the room with the doc and I'm going to say, okay, you want me to do all this stuff, like how much is that going to cost? They don't know, right? So to build some easy mechanisms that you can make the information available to consumers at the point at which they need it is essential. But the other, and I think more powerful strategic purpose for doing that, which would point to a different place or a point in time at which you would make information available, is that there is some evidence that it's not actually the consumer use of price information or even of quality information that is driving the system and putting pressure on the system. It is simply the public availability, the fact that other hospitals and doctors can see, the prices or the quality ratings, et cetera. But the economics in healthcare aren't the same as in the private market, I think, as we all know. And so it limits the pool of consumers who are really the ready audience. So I would say you should segment and figure out who are the consumers most likely to use the information and where are the points at which they need it and deliver it in, at those right moments. But I think I'm not saying that it should only be targeted there, because I think there is a much broader public good in bringing transparency to both cost and quality data in healthcare. The one word of caution is that we do have to be careful, because consumers equate higher costs with higher quality, right? Because that's what happens. When I buy a Lexus versus, a Ford Focus, I think I'm getting higher quality at the higher price. So it's not stupidity or lack of knowledge. It's very intuitive when we live in a retail world and the rest of our life. So we have to be careful about pairing that information together so that they see that this is really about getting the care you need in a really high quality way, and you're getting value at the same time, although don't use the word value. I see Chuck in the back of the room. Value is a 4-letter word for consumers.
Well, please join me in thanking Christine for her participation in the meeting and her comments, and for the steadfast work of the National Partnership in advancing the cause of meaningful patient engagement.
Thank you very much.
So thank you.